So I think that, so the question becomes is can we reduce the overall cost? And I think that kind of is a good segue, with my previous response. And I think we need to be a more acutely aware and standardize our admission practices for patients who present to the ED with community-acquired bacterial pneumonia, with suspected or documented community-acquired bacterial pneumonia. If possible, PSI or port score should be calculated. It should be taken into account. If there's an opportunity to treat the patient briefly in the observation unit, this should be preferred over a short hospital admission. On the flip side of that is among our admitted patients, what we're finding is there's a number of studies, a large of this is generated outside the US, is a lot of patients with infections stay in the hospital past infection resolution. So I think a lot of times what the decision is, the patients start on IV antibiotic, even though their infection resolves and they're improving. I wouldn't say they're back to their baseline, but they're improving. They tend to stay in the hospital longer than they probably necessary. If one considers each day of hospitalization for a community-acquired bacterial pneumonia patient is $2,500, even a 1 or 2 day hospital reduction could have a substantial impact on overall cost of care. So really, I think it's really twofold. Better triaging patients who present to the ED, admitting patients who need to be admitted, and for our admitted patients, really when their infection resolves and is their opportunity to discharge to home to do so. And this is usually 24 hours after they have clinical stabilization and improvement in some of their symptoms. So new options. So as I mentioned before, we only have a limited number of classes available for community-acquired bacterial pneumonia. We have our beta-lactams, our penicillins, and cephalosporins. We have our respiratory fluoroquinolones, which is levofloxacin and moxifloxacin. We have macrolides, which we can only use in combination, as well as doxycycline. So beyond them, we had 2 drugs recently approved. Lefamulin, which is a pure mutaline antibiotic, available both IV and PO, recently indicated for the treatment of adults with a community-acquired bacterial pneumonia. Also we have amaticycline, which is a next-generation tetracycline type antibiotic, which is indicated for both patients with acute bacterial skin and skin structure infections, as well as adults with community-acquired bacterial pneumonia. Similar to lefamulin, amaticycline is available both IV and oral, but per its packet insert for patients with community-acquired bacterial pneumonia, IV should be started because this was the practice within its clinical trials. So right now, they have no oral-only data among patients with community-acquired bacterial pneumonia with amaticycline.